Kitulwat, I'm sorry, consultant pediatric intensivist, Lady Ridgeway Hospital, Colombo. Thank you, Dr. Vishnu. He has arranged so many webinars so far. It's about maybe 15 or 20 webinar has been done within this last maybe 1-2 months time. So with that, I will let Dr. Vishnu to introduce Dr. Nalin. Thank you, Nalin, for accepting our invitation. Dr. Vishnu will introduce you. Thank you.
Yeah, thank you very much, sir. And it's my great pleasure to introduce our speaker today. Especially it's our special speaker, Dr. Nalin Kitulwat. Actually, I have worked with, under him, under his supervision when I was a SR. So he's a pediatric intensivist working at the hospital for children, Colombo, and he's a founder president of Untitled Chapter of Sri Lankan College of Pediatrician. And having said that, he is managing a lot of patients with MIS-C, and he is contributing to the national level guideline formation and the other things also to improve the health of the children of our country. So with that kind of small introduction, I'll invite Dr. Nalin Kitulwat to go ahead with his presentation. Thank you very much, sir, for accepting our invitation to present to the BMA. Thank you very much. Our country. So if you find
echoing, Vishnu.
Invite Dr. Nalin. Can you all hear me?
Yeah, we can. Dr. Nalin, do you want to, the questions you want to anyone and can interfere in between, or you want the question at the end?
At the end, of course.
At the end, okay.
Yeah. Good evening, everybody. At the onset of this lecture, I would like to thank the Particular Medical Association and especially Dr. Vishnu to organizing this. And Vishnu, thank you for that kind introduction. Today, we are going to discuss a relatively new disease. In fact, this is gradually invading our country. So I'm going to discuss about the diagnosis and management. As I mentioned, the MIS-C is a new disease. It's a post-COVID disease. Initially, we thought it's only in children, and it's a rare disease. The incidence is about 1 in 5,000, but it can be fatal. About 2% of the children, or 2% of the patients can die of it. Keep long-term sequelae also. And the important thing is, if you detect early, it can be treated. So it's a new disease. The first reported case of MIS-C is in last year, 2020, April, in United Kingdom, later in USA, now worldwide. And the important thing is, again, the evidence is changing. Every week, there are so many articles on this. And since this is a new disease, it's better for us to live with this and read more and more literature about this disease. So initially in the UK, they have named this disease as pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2. They call it PIMS-TS. Later, in the US, they have renamed it as multisystem inflammatory syndrome in children. So WHO has selected MIS-C. So in Sri Lanka also, we have selected MIS-C as the name of this disease. So it's a post-COVID disease. Usually after 2 to 6 weeks after the COVID, these patients are presenting. But the important thing is, as we all know, most of the time, children with COVID are asymptomatic. Sometimes some of these patients that we have managed, nobody knows that these children has had COVID. So they may be having mild cough and cold about 2 weeks or 1 month back. Nobody is noticing this. So sometimes your patient or the parents nobody around them is aware about the COVID situation. And this is published in New England Journal of Medicine last year, July. So what they say is, whenever you are having a surge of COVID infection like this, after about 1 month, we will see the MIS-C surge. Exactly that is what is happening in Sri Lanka now. Now we are seeing more and more MIS-C. I have admitted about 5 patients of MIS-C today itself to our ICU. So it's very important to know about disease and understand about the physiology. Initially, we thought it's only in children, but now evidence is there. It's occurring in adults as well. And not only that, even in neonates. I'm going to touch a little bit about these two entities also. So epidemiology, we know the COVID-19 patients, only 14% are children. We think about the COVID-19 hospitalizations, 1.3 to 3.1 are children. And if you think about the COVID-19 positive children, only 0.1 to 1.9% are needing hospitalization. So that is about the COVID. And if you think about the epidemiology of MIS-C, again, it's a rare disease. Usually 5,000 cases to one MIS-C case for 5,000 cases of COVID. And usually it's 8 to 11 years the most patients are belongs to, but it can happen below 21 years. They are usually obese, previously well, and mortality is about 2%. So far, up to today morning, we have managed about 71 cases of MIS-C in our ICU at LRH. The first case we detected in Sri Lanka in early part of this year. Our patient population is below 17 years, youngest is 2 months, less than 12 years, about 78%, male preponderance about 60%. So far, from these 71 patients, we had 3 deaths. As I mentioned, now more and more cases are reporting. National level, the reported cases number is around 200 now. Most of the places now we are managing, including the particular the hospital, and LRH wards are, some of the wards are having MIS-C patients, and it's presenting with all over the country. So that is important. I like to mention this also. We first think about the MIS-C. Now, if we think about the MIS-C cases, is about 200. If you know that 1 in 5,000 is the incidence rate of MIS-C, the total COVID infected children should be about 1 million. So that is the alarming thing. So this is the tip of iceberg. So we are having a lot of patients. So a little bit about pathophysiology. It's not well understood. We think it's an autoimmune disease. Basically, it's an abnormal immune response to virus, unbalanced cytokine responses, vasculitis, endothelial damage, thrombosis. These are the things that we are suspecting as for the pathophysiology. And clinical features, usually it is 2 to 6 weeks after COVID. You get fever, you have mucocutaneous symptoms, rash, conjunctivitis, red or swollen lips, strawberry tongue, myalgia, swollen hand, feet, and cervical lymphadenopathy. So this is the typical pattern of MIS-C rash. So this is one of our patients. So it's a palpable, vasculitic type of rash, and sometimes the nose and the eyelids are also involved. And the other important clinical feature is GIT problems. They present with abdominal pain, vomiting, diarrhea, mimicking appendicitis. In fact, 2 of our patients has undergone a surgery thinking that it's appendicitis before diagnosing MIS-C. So that is very, very important. All the other organs also can be involved. At the moment, I have one patient with 17 years with CNS involvement. So no system is spared. So this is a case series published in BMJ in October 2020. So GIT symptoms about 87%, fever 82%, cardiac disorder 75%, skin 71%, shock 67%. So this is our case series, 71 patients. Mortality is about 4%. So these are the common symptoms that we have came across: fever, severe involvement, GIT, eye, skin, lymph node, respiratory system, CNS. And in CVS manifestations, hypotension has been seen 75% of the patient who are admitted to ICU, shock in 50%, elevated troponin 9 10%, and abnormal echo in 10%. As I mentioned, this is very important symptoms. Abdominal pain has was the symptom in 43%, vomiting and diarrhea also 54 and 65% each. CRP was elevated in 87%, ESR 70%, D-dimers more than 10 times, it's 58%, ferritin in 17%. And about the COVID diagnosis, none of our patients are positive for that. Obviously, this is not a common thing in acute COVID. PCR was positive in 50% and antibodies are positive in 60%. Right, so how to diagnose MIS-C? So WHO case definition says this is very, very important because you should not miss MIS-C. At the same time, you should not overdiagnose MIS-C. So to diagnose MIS-C, these features should be a must. So this is MIS-C for the children. So age should be below 21 years. Fever should be more than 3 days. Elevated inflammatory markers should be there. And there shouldn't be any other explanation for this in elevated inflammatory markers and evidence of COVID-19. Evidence of COVID-19 means it may be RAT, it may be PCR, it may be antibodies, it may be even a positive contact history. So if these 5 things are there, you are looking at the other symptomatology. So 2 of the following are needed if these first 5 things are there. IO, skin involvement, hypotension, shock, myocardial dysfunction, coagulopathy, GIT problems. So that is very important to go through this one by one. Age, fever more than 3 days, elevated inflammatory markers, no other explanation for these elevated inflammatory markers, evidence of COVID, and 2 of the symptoms. So otherwise you are overdiagnosing MIS-C. So we have prepared this guideline in July 2021, the management of multisystem inflammatory syndrome in children. This is a multidisciplinary guideline involving pediatric intensivists, pediatricians, pediatric cardiologists, rheumatologists, and hematologists. So it's very comprehensive guideline. So it's the freely available. The online version is freely available. So you can, if necessary, you can ask from Vishnu. And later, the health ministry also have endorsed this. They have published this as a circular. So now we know how to manage. So after diagnosing, so this MIS-C is a clinical spectrum. Basically, we have 3 clinical pictures. We name it as severe MIS-C, Kawasaki disease phenotype, and mild MIS-C. So we call it a severe MIS-C when you're having a markedly elevated inflammatory markers, severe multi-system involvement, cardiac involvement, shock, neurologic manifestations, and other manifestations requiring PICU care. So anything needing PICU care, severely ill children with MIS-C is severe MIS-C. The Kawasaki disease phenotype means these patients meets criteria for complete or incomplete Kawasaki disease and no shock or severe multisystem involvement. If there's shock or severe multisystem involvement, they will go to this severe MIS-C category. And the other component is the febrile inflammatory state or the mild MIS-C. They will have persistent fever and other symptoms like headache, fatigue. Inflammatory markers are maybe elevated, but no evidence of shock or cardiac dysfunction. So if they are not belonging to severe MIS-C or Kawasaki disease phenotype, then it should be mild MIS-C. So here itself, we will see because what is the difference between MIS-C and Kawasaki disease? Because some of these the symptoms are overlapping. So usually Kawasaki disease, as pediatricians we know, is below 1 year and very young children. But MIS-C is older. And GIT symptoms are common in MIS-C, but rare in Kawasaki disease. Myocardial dysfunction and shock is common in MIS-C, but in Kawasaki disease, what is happening is coronary artery changes dominate. And inflammatory markers are more elevated in MIS-C than Kawasaki disease. So this is how we differentiate whether this is pure Kawasaki disease or Kawasaki disease phenotype of MIS-C. Then about the management of severe MIS-C and Kawasaki disease phenotype. So they are same, whether you are in the severe MIS-C category or Kawasaki disease phenotype, the management is same. So we have shock or multi-organ dysfunction syndrome. So you have to give IVIG 2 grams per kilo, maximum is 100 grams over 24 to 48 hours, plus IV methylprednisolone 30 milligrams per kilo, maximum is 1 gram over 30 minutes for 3 to 5 days. So these two are important if it is in severe MIS-C or Kawasaki disease phenotype. Then we are assessing if the treatment failure is there, you can give second dose of methylprednisolone. So if even after the second dose of methylprednisolone, if the treatment failure is there, you have to consider adjunct therapies. So a few of our patients needed second dose of IVIG, but none needed adjunctive therapies. So this is how we categorize or how we define the treatment failure. If the persistent fever more than 48 to 72 hours after IVIG, persistently high CRP 48 to 72 hours after IVIG, and recurrence of fever within 7 days of completion of IVIG. So if they are there, we think this is treatment failure. So that is about severe MIS-C and Kawasaki disease phenotype. And then we come to the mild MIS-C. So here, the fever and mild inflammatory status are there. No shock, no Kawasaki disease phenotype, or organ dysfunction. So we have to exclude other etiologies, perform the Tier 1 workup. All these things are there in our guideline, and monitoring the ward and look for severe features. So if they have severe features of MIS-C or Kawasaki disease, already we have discussed how to manage. If they don't have features of Kawasaki disease or severe MIS-C, and if there is evidence of worsening, if the child's condition is not improving, again, you have to think about the management. So if the evidence of worsening is there, consider other etiologies. At the same time, consider giving IVIG plus methylprednisolone. But here, the dose is a small dose, methylprednisolone 2 milligrams per kilo per day in 2 divided doses. So not 30 per kilo. So if it is not severe disease, we are giving a small dose of methylprednisolone plus IVIG if the child's condition is not improving. And if the child's evidence of worsening is not there, monitor in the ward and manage accordingly. So it's a spectrum, but management is very straightforward. So a little bit about drugs, how to give and all these things. Again, I'm highlighting, get these SLCP guidelines. All these things are there. The formulary and drug doses, everything is there in the appendix. So it's very, very useful. So IVIG is needed for Kawasaki disease phenotype, severe MIS-C, and worsening MIS-C. So all these three categories needing IVIG. The IVIG dose is 2 grams per kilo, maximum is 100 grams. So we are giving it as a single infusion over 24 to 48 hours. If the patient is obese, it's better to calculate these the drug doses for the ideal body weight. And as I mentioned, we can give second dose in refractory disease. So blood should be drawn for serologic testing of COVID-19 and other pathogens prior to administering IVIG. As you know, after giving IVIG, sometimes these investigations are not very accurate. And this is also very important because after giving IVIG, the ESR will be high. So don't use ESR to monitor the disease. The ESR may not be reducing, because IVIG. So no point using ESR after giving IVIG. So following up of ESR is less useful after IVIG. About methylprednisolone, if the patient is mild MIS-C, we are giving, it should be IV again, but 2 milligrams per kg per day in 2 divided doses. With a severe disease or Kawasaki disease phenotype, it should be pulse therapy. It's IV, 30 milligrams per kilo per dose. Maximum is 1 gram, again 3 to 5 days. And once the patient has improved clinically, can be transitioned to 2 milligrams per kg per day of oral prednisolone. Maximum is 60. And gradually, we are tailing off this the steroid over 2 weeks. So methylprednisolone, mild MIS-C, 2 milligrams per kilo in 2 divided doses. Severe MIS-C and Kawasaki disease phenotype, it should be 30 milligrams per kilo. Maximum is 1 gram, 3 to 5 days. After that, you can convert it to oral prednisolone, 2 milligrams per kg per day, and tail it off over 2 weeks. All MIS-C patients needs aspirin. So we are using low dose aspirin. It's 3 to 5 milligrams per kg. Maximum is 75 milligrams per day. And aspirin should be continued for 2 months, 4 to 8 weeks. And sometimes in Kawasaki disease phenotype and some severe MIS-C, the longer duration is needed. We have to continue aspirin for longer duration. And continue until platelet count becomes normal or coronary artery becomes normal if there are changes in the echo. And these are contraindications for aspirin. If the platelet count is less than 50,000, active bleeding, bleeding diathesis, platelet dysfunction, the diseases, or allergy to aspirin, you can't give aspirin. Then about enoxaparin. Again, why we have to give enoxaparin? All these patients are at risk of experiencing thrombotic complications due to hypercoagulability associated with COVID-19. Then MIS-C itself is a major risk factor for venous thromboembolism, including deep vein thrombosis and pulmonary embolism. And severe LV dysfunction are at risk of apical AV thrombus, and those with coronary artery aneurysms are at risk of myocardial infarction. So there's a high chance of having clots everywhere. So better to give enoxaparin in these patients. So indications are these: current or prior VTE, severe LV dysfunction, large or giant coronary artery aneurysm, markedly elevated D dimers. So if these three are not there, we are going by the D dimers. Most of the time, the case series, the indications for enoxaparin is D dimers. If the D dimers are more than 10 times of normal levels, we have to give treatment dose. If it is elevated but less than 10 times of normal level, we can give prophylactic dose. And again, the contraindications: if the platelets are less than 80,000, active bleeding, bleeding diathesis, fibrinogen level is less than 1 gram, you can't give enoxaparin. And dose, again, the college guidelines contains everything. So treatment dose is for current or prior VTE, severe LV dysfunction, large or giant coronary artery aneurysm, severe MIS-C, and patient with less severe MIS-C if the D dimer level is markedly elevated more than 10 times. Prophylactic dose, patient with less severe MIS-C and D dimer level is less than 10 times of the upper limit of the normal, or with the patient with risk factors for thrombosis like thrombotic, the nephrotic syndrome, they have to get enoxaparin. So we have to continue D dimers at least for about 10 days. Sorry, we have to continue enoxaparin at least for about 10 days. And after 10 days, we are repeating the D dimer level. And if the D dimer level is normalized, you can discontinue enoxaparin. If the level is between normal and 10 times upper limit of normal, convert to the prophylactic dose. And again, repeat the D dimers in 10 days. That is again important. No point repeating D dimers in each 3rd day or 5th day. So repeat D dimers after 10 days. And sometimes enoxaparin again, we have to give longer duration or switching over to warfarin. It should be decided by the cardiologists and the hematology teams with ongoing severe cardiac dysfunction, documented thrombus, suspected macrophage activating syndrome. These are the indications to continue a longer duration of enoxaparin. And as I mentioned, this dose, treatment dose is below 2 months. It's 1.5 milligrams per kg per dose BD. Above 2 months, it should be 1 milligrams per kg per dose BD. Prophylactic dose below 2 months is 0.75 milligrams per kg per dose BD. More than 2 months is 0.5 milligrams per kg per dose BD. Sometimes, because of the hypotension, we have to use inotropes. Epinephrine or the adrenaline is preferred over noradrenaline because most of the time they have ventricular dysfunction. So on top of the ventricular dysfunction, if you start noradrenaline, that is an added burden to the heart. And you can use milrinone or dobutamine with a left ventricular dysfunction with stable blood pressure. So if the blood pressure is normal, you can go for milrinone or dobutamine. If the blood pressure is unstable, you have to go for adrenaline. And this is also important. You don't need a central line to start these drugs. You can commence via peripheral line until we arrange the central line. So don't delay. Antibiotics, again, for all patients, because the COVID-19 patients are at high risk of secondary co-infections. And patient presenting with severe multisystem involvement, anyway, we have to start antibiotics because it may be part of the septic shock disease. And usually we are starting with cefotaxime with vancomycin or flucloxacin or teicoplanin with piperacillin tazobactam. And follow-up, again, follow-up is needed with the pediatric and pediatric cardiology. And if we decide, we can ask the rheumatologist as well as the hematologist to be in this follow-up team. So definitely follow-up is needed after 2 weeks, 6 to 8 weeks, and 12 months. So we know that even after 12 months, some patients are having some problems. So that's why it is needed. So then the cardiologist or the team will decide whether they need longer follow-up. So this is our guidelines. Sri Lanka College of Pediatricians, Management of Multisystem Inflammatory Syndrome in Children, July 2021. So if you are interested, you can ask from one of the pediatricians. So it's freely available as the online copy. And so this is the summary in MIS-C management. We know that MIS-C has 3 categories: shock, Kawasaki disease phenotype, mild MIS-C. So if you're in a shock or multi-organ dysfunction, this is severe MIS-C. We have to manage shock, then IVIG, methylprednisolone, antibiotics, aspirin. So if it is a Kawasaki disease phenotype, IVIG, methylprednisolone, aspirin. And mild MIS-C, aspirin, clinical monitoring, and no improvement, you have to consider methylprednisolone and IVIG. Sometimes patients are presenting with shock. So nowadays, if a patient presents with shock, you have to think about 3 main diseases. It may be septic shock, it's very common. It may be dengue shock, dengue also coming now, and it may be shock phenotype of MIS-C. So if the patient is presenting in shock, this is how you should manage. They are again the guideline. So as usual, you are connecting the multi-parameter, monitoring the vital parameters, stabilizing airway and breathing, 2 wide-bore cannulae, and you are taking blood for these things and including the investigations for MIS-C. And your usual pattern, you are giving 20 ml per kilo normal saline as a bolus and starting vancomycin and cefotaxime after taking the blood culture. So then you have to reassess with the CRFT, pulse rate, pulse volume, and blood pressure. If there's a positive response, that means if the child is improving, then you have to continue monitor, trace the report, consider inotrope, and if the MIS-C criteria are there, you have to follow the MIS-C guideline. But if the patient is not improving, you can repeat the 20 ml per kilosecond bolus and look features of heart failure and fluid responsiveness. And then you have to consider inotropes plus methylprednisolone and IVIG. Because again, as I told you, if the child presents with these days is shock, the 3 main important diagnoses are septic shock, dengue, and MIS-C. If the child is not improving, it's better to give at least for the first dose until you get the proper diagnosis with investigation. As I mentioned, this is again published in 2020 November. So you can see this blue dotted line is the COVID cases, and this red line is for MIS-C. So this is exactly what is happening at the moment in Sri Lanka. We had very bad surge in COVID-19 patients. Now we are seeing more and more MIS-C patients. So this is the disease pattern, COVID disease pattern recently. Right. So what will be our future? So you will see more and more cases of MIS-C. And not only that, more children will be antibody positive. So then you will have more and more dilemmas. So child may be presenting with septic shock, but when you do COVID antibodies, antibodies are positive. So whether this is septic shock or MIS-C shock phenotype. So you have to answer these questions. And evidence is changing. So you need regular updates because every day it's changing. So since it's a new disease, even though we are doing this lecture now, this may be changing within about a month. And what should we do? What we should do? Don't miss MIS-C. That is very important. And at the same time, don't miss other common diseases. I'm stressing this, sepsis and dengue are commoner than MIS-C. And don't overdiagnose MIS-C because all the cases you see are not MIS-C. And if you take one by one, don't miss MIS-C. So COVID-19 is having non-specific symptoms. So you will not get the past history of COVID-19, most of the patients with MIS-C. So you have to consider MIS-C if the patient is having fever, abdominal symptoms, particularly if they develop conjunctivitis. And there may be MIS-C overlapping symptomatology with sepsis, toxic shock syndrome, myocarditis, meningitis. So all ill children, your differential diagnosis should include MIS-C these days. Especially if your patient is between 8 to 20 years, well-grown, fever for about 3 days, severe abdominal pain, rash, conjunctivitis, disease unless proven otherwise, MIS-C. We have admitted 2 patients of this type of this symptomatology to our ICU today itself. And don't miss other common diseases. As I mentioned, MIS-C is a rare disease. This happens in 1 in 5,000 COVID positive children. We have more common diseases. So don't miss common diseases. We have seen meningococcal sepsis managed as MIS-C. We have seen COVID positive urticarial rash managed as MIS-C. We have seen dengue managed as MIS-C. And not only that, we have seen chlorine inhalation ARDS managed as MIS-C. So don't do that. Common things are common, so we need more clinicians. And don't overdiagnose MIS-C. MIS-C is a diagnosis by exclusion. So stick to this WHO guide, the criteria to diagnosis, WHO case definition. So 6 things should be there. You need the age definition, then fever more than 3 days, then inflammatory markers should be elevated, then you don't have any other explanation for this increased inflammatory markers, and there should be some positive thing for the COVID, either contact history, RAT, PCR, or antibodies. If you have these 5 things, then look at the other symptoms. In 2 system involvement, it may be rash, it may be shock, it may be abdominal symptoms, or CNS or any other thing. So in future, as I mentioned, most of the children will have COVID antibody positivity. So you will have dengue with COVID antibody positive. You will have leptospirosis with COVID antibody positive. You will have septic shock with COVID antibody positive. So all the cases you see are not missing. Little bit about MIS-N. Again, this is happening in Sri Lanka now in neonate. We think it's the transplacental transfer of maternal antibodies. So mother is getting the disease, mother is producing antibodies. So these antibodies can cross placenta and causing the multisystem inflammatory syndrome in neonate. So basically it's an alloimmune disease. Now increasingly reporting in Sri Lanka, we have heard about at least 3 deaths with MIS-C, and 1 or 2 patients have survived. So think about this whenever you are resuscitating a newborn these days. So a little bit about how to transfer the disease from mother to newborn. It may be intrauterine transmission. It may be intrapartum transmission with the exposure to infected maternal blood, and it may be immediate postpartum transmission. So these are the possibilities. So there may be 5 categories of patients. So the pregnant mother may be positive. The child may be positive after the first week. So this is late onset neonatal COVID-19. So pregnant mother may be negative, child also negative. Somebody else can give the disease to the child. So it's again late onset neonatal COVID-19. So here the pregnant mother is positive. So mother can give the disease to the baby. As we explained, 3 ways. Early onset neonatal COVID-19, about 2% are there in US. So these patients can develop MIS-C later. So it is a neonatal multisystem inflammatory syndrome. And sometimes the positive mother is with negative child. And sometimes the category E is mother is positive. Then mother is producing antibodies. And mother is giving antibodies to the patient or the child, the newborn. So the child can develop MIS-N. So be careful. They can present with various things. So they will have hyponatremia, oliguria, renal failure, and so on, feeding intolerance, vomiting, necrotizing enterocolitis presentation. They will have hypoxemia, pulmonary infiltrate, PPHA, and they have very good response to IVIG therapy. So still we don't know how to manage these patients properly. Then MIS-N guidelines we have not prepared, but we are doing the same thing as MIS-C. So you can do the investigations. It may be DIC, like decreased fibrinogen, increased D-dimers, thrombocytopenia, neutropenia, lymphopenia. So the important thing is you can treat with IVIG. MIS-A, this is in adults. So this is a Journal of American Medical Association, published in May this year. The multisystem inflammatory syndrome in adults with COVID-2 infection, another piece of expanding puzzle. So now again, this disease is happening again and again in adults. So at the moment, I have one patient with a 17-year-old girl admitted managing in our ICU, and 22-year-old patient is in HSL, and I have heard about several other patients are also present in even the particular area. So don't miss, this is again a new entity. So what they say in MIS-A, significantly they are younger patients. Then this is very, very important. Overlapping symptoms of acute COVID-19, about 60% overlapping symptoms of acute COVID-19. That means they may be having COVID pneumonia. On top of that, multisystem inflammatory syndrome. So not like in pediatrics. So this can happen with acute COVID. So ICU admissions about 33%, shock in 20%. So what they say is it is likely that among those diagnosed with severe or critical acute COVID-19, a proportion are cases of MIS-A. So again, so far we have managed with IVIG and methylprednisolone with good results. So this is the CDC case definition of MIS-A, more than 21 years, hospitalized for more than 24 years, or with an illness resulting in death, who meet the following clinical and laboratory criteria, and no alternative diagnosis for the illness, similar to MIS-C. These are the clinical criteria: severe cardiac illness, rash and non-purulent conjunctivitis, and secondary clinical criteria: new onset neurologic signs, shock or hypotension, abdominal pain, vomiting or diarrhea, thrombocytopenia. It's similar. And with COVID-19 infection, elevated inflammatory markers, at least 2 of the following: CRP, ferritin, IL-6, ESR, procalcitonin, and positive COVID-19 test. So Sri Lanka, several young deaths due to COVID has happened. And we have heard that most present with abdominal pain. 2 cases mimicking appendicitis. Whether they are MIS-A is, we don't know. And we are now seeing more and more case reporting, as we say. So be vigilant, be careful when we are managing patients. So in summary, so it's a new disease. It's a post-COVID syndrome, only in children. That's what we thought. Now, neonates as adults also, this is happening. And it's rare, 1 in 5,000. It can be fatal. The mortality rate is about 2%. Long-term sequelae may be there. We know that up to about 1 year, the cardiac problems will be there. it can be treated. That is important. So don't miss MIS-C. Don't miss other common diseases because it's a rare disease, and don't overdiagnose MIS-C. So we need more and more clinicians. You have to go through the patient's history, examination, investigation, and come to a proper diagnosis. Thank you very much.